Good afternoon. I'm Linda Ehrlich-Jones from the Center for Rehabilitation Outcomes Research at the Rehabilitation Institute of Chicago, and it is my pleasure to welcome you to our webinar, Outcome Measurement Selection in Individuals with Spinal Cord Injury. Our speaker this afternoon is Jennifer Kahn, PT, DPT, NCS, who's an assistant professor at Northwestern University Feinberg School of Medicine in the Department of Physical Therapy and Human Movement Sciences. And she practices as a clinical physical therapist at the Rehabilitation Institute of Chicago. She received her board certification in neurologic physical therapy in 2007 and has been working with individuals with SCI throughout her career, both clinically and in research. Dr. Kahn served as the chair of the American Physical Therapy Neurology Section, SCI EDGE Task Force, a group that is responsible for recommending outcome measures for educators, researchers, and clinicians to use with individuals with SCI. Our webinar today is sponsored by the Center for Rehabilitation Outcomes Research and supported by a grant from the Paralyzed Veterans of America Education Foundation, grant number 739. Welcome, Dr. Kahn.
Thank you, Linda, and thank you everyone for joining me today. And I appreciate you taking time, maybe out of your lunch, depending on the time zone that you're in. And I appreciate you welcoming me to your desks or conference rooms, therapy gyms, offices, or your homes, wherever else you may be watching or listening to this today. So the objectives for today, we'd like to describe the process of the Spinal Cord Injury Task Force to make recommendations for use of outcome measures in the spinal cord injury population, and identify recommended outcome measures to use with individuals with spinal cord injury across all domains of the International Classification of Function, Disability, and Health. And hopefully I'll be able to help you integrate some of these outcome measures into your clinical practice when treating individuals with spinal cord injury. And along the way, we'll identify some gaps in the areas of outcome measures in spinal cord injury rehabilitation. I'd like to start off by identifying what is EDGE. So some of you may hear EDGE and think of something like this. This is a view off the edge of the Grand Canyon, actually. But after today, I'm hoping that you'll be hearing the word EDGE and think of things like this, tools that we use to measure change in our patients. And in the upper right-hand corner, it's a little bit tough to see, but that is what we call the EDGE form. And you'll be much more familiar with this form after the end of the presentation. I'd like to give you a little bit of history about the EDGE and a little background. So EDGE actually stands for Evaluation Database to Guide Effectiveness. And in 2006, the research section of the American Physical Therapy Association, led by the chair Adele Field-Fauteuil, formed the EDGE Task Force. And this was to advance the process of agreeing on the best outcome measures. Again, EDGE standing for Evaluation Database to Guide Effectiveness. And the neurology section of the APTA has really been pivotal in this process by forming its own EDGE task forces. First, there was the stroke EDGE to develop outcome measure recommendations for individuals with stroke. This was followed by the group for multiple sclerosis. Next came our group for spinal cord injury, working simultaneously with the group who recommended outcome measures for traumatic brain injury. And finally, after our group came the Parkinson's disease and vestibular groups. So there now has been 6 EDGE groups sponsored by the neurology section of the APTA. So let's think for a minute why we use outcome measures. And you can think in your clinics why you use outcome measures. We'll discuss a couple reasons here. Accountability. We want to be accountable for our patients. We want to show effectiveness of the interventions we use. And of course, we have to answer to our payers. We have to show that we are indeed making change in our patients. Communication between our sites of care. It's often helpful if, let's say, you're working in an outpatient clinic, if you receive notes from the inpatient site of care, to know and have an objective set of outcome measures to understand where your patient was when they left inpatient. And finally, using outcome measures can really enhance our clinical reasoning. For example, an outcome measure can give us information about fall risk. We can understand potentially where our patient is at relative to safety and fall risk by looking at the result of an outcome measure. Understanding the results of outcome measures can help us plan our interventions. A patient's performance on outcome measures can help us really contribute to the overall plan of care and, again, enhance clinical reasoning. But of course, we have lots of different kinds of outcome measures that capture different constructs. So let's take strength, for example. Strength is a measure that's pretty safe to say many of you out there use and measure. We want to know how much strength our patients have, and we want to understand if their strength is improving. But it's not just enough to know how much strength they have and if their strength has improved. We need to know if that strength is contributing to their improvement in their function. But we really can't stop there. It's important to know how that improved function is improving their life and their quality of life. So if we look at this continuum, we need to measure change at all levels of the ICF, or International Classification of Function, Disability, and Health. So this is another way to represent what I just talked about. When an individual has a health condition, it results in impairments in body structures and functions. Someone gets activity limitations and participation restrictions. And these are influenced by environmental factors and personal factors. And as clinicians, we need to uncover how these interact, and it's best to have standardized outcome measures that look at each of these areas, as illustrated on a previous slide. Well, it's easy for me to say this, but it really isn't that easy, and there's many barriers or hurdles that we face every day. We have a limited access to information, perhaps. There may be some knowledge gaps. We may have a limited amount of time. Certainly, cost could be an issue. And there may be a lack of equipment to use certain outcome measures. Clinicians face these barriers every day. And how can a busy clinician be expected to sift through the immense amount of information to be able to make these informed decisions? There are many outcome measures available, and it could be potentially very overwhelming to people to know which one to select. So we have to figure out how we can jump over these hurdles to figure out the best possible choices to make for our patients. So that is where the goals of the Spinal Cord Injury EDGE Task Force come in. So our goals were to really help try to alleviate some of these barriers that clinicians face and to help increase the use of outcome measures specifically related to the spinal cord injury population. So if we look at the bottom line here, we wanted to assist clinicians, researchers, and educators to select and use outcome measures relative to the SCI population based on a thorough review of psychometric properties and clinical utility. So how did we do that? We did that through a modified Delphi process, which basically means a multi-step expert consensus process. And we also collaborated with the Rehabilitation Measures Database, or RMD. So RMD was developed to help clinicians and researchers identify reliable and valid instruments. And this database provides evidence-based summaries that include concise descriptions of each instrument's psychometric properties. That sounds kind of familiar, right? I just said a statement that sounded very similar to that. So if you recall the goal of the Spinal Cord Injury EDGE group, that sounds very similar to the goals of the RMD. So the EDGE and the RMD was a very natural pairing to work together. And these two groups decided to come together to improve each other's outcomes, really to build the best product for therapists and other clinicians, researchers, and educators. And this was unique to both the spinal cord injury and TBI EDGE groups, which I mentioned worked simultaneously. And I mentioned the stroke and MS groups came before us, but this pairing of the RMD and the EDGE groups was unique to our groups. That started with our groups working together. So as we started looking at outcome measures, I'll break this down a little bit for you. We started with 133 measures that we gathered from a variety of sources, and we had to narrow that down. We had about a 9-month time frame. So our consensus group, through a consensus process, we narrowed that down to 63 measures. We felt that was a reasonable number of measures to review in the time that we had. And we didn't attempt to break it down this way specifically. This is just how the numbers fell. So what you see here are graphs reflecting the measures in the constructs related to the ICF. So we ended up with 17 measures that looked at impairments in body structures and function, 16 measures that reflected constructs in the participation domain, and 30 measures that reflected constructs in the activity domain. And in the lower right, you see this broken down a different way. We had 34 measures reflecting performance-based measures and 30 measures reflecting self-report. Now, it's still early. Hopefully I haven't lost you yet. If you're paying attention, you'll see that these numbers don't totally match. You'll see that there's 64 measures represented in the lower right-hand corner. And that's because one of our measures was actually a combination of performance-based and self-report. How did we rate these measures? This was the scale that we used. We had a 4-point scale, and to simplify that scale, basically started with a 4 of highly recommend, all the way down to a 1 of a do not recommend. This is a lot of information, but what I want to make clear here is these ratings were defined by 2 things. It combined strength of psychometric properties and clinical utility. So before I discuss that further, I'd like to just take a second to quickly review psychometric properties. We broke this down based on 3 common themes. So reliability, validity, and the responsiveness or interpretation of change. That's what we were looking for each measure. Did a measure have reliability? Was there consistency, reproducibility of a result? Basically, was the measure error-free? Secondly, did the measure have validity? Did the measure represent what it was intended to measure? There are a variety of types of validity. I have 2 listed here just as an example. And then finally, the third psychometric properties that we looked for was something relative to the ability of interpreting the result of the measure. Did it have responsiveness? Did it have something relative to the interpreting change in the measure? So these are the kinds of questions. Did the measure detect change? What did that change mean? And here are some of the examples of things that we looked for. Was there data in the literature to show that this measure had standard error of measurement, minimal detectable change, and minimally clinically important differences? And we'll come back to this a little bit later. So if we go back to our rating scale, we can further define, for example, what a highly recommended measure is by looking at a 4. So a 4 would have excellent psychometric properties, meaning it was valid, it was reliable, and it had that third property about available data to guide interpretation. It also would have excellent clinical utility, defined by administering in less than or equal to 20 minutes, equipment typically found in the clinic, you didn't have to pay for it, it was easy to score. And then it goes down from there. So a 3, for example, it may lack information about some of these psychometric properties, might take a little bit longer to do, some additional equipment, and so forth. Now that we have some background on how the EDGE recommendations were made, let's move forward and talk about the rest of the process. So the primary reviewer, let's take an example of the walking index for spinal cord injury, which some of you may be familiar with. Let's say I was the primary reviewer for the walking index for spinal cord injury. I would look at that measure, I would make a rating about it, and then I would go to the rehabilitation measures database and I would review the summary if it existed, or I would create a new one for RMD if it didn't. I would pass that rating along to my secondary reviewer. We would either agree or work out any disagreements that we had. That would happen for all 63 measures. Once that occurred, we would put all that data into a survey, and each member of our task force would look at each rating, whether they agreed or disagreed, and any disagreements would be resolved until there was consensus on all 63 measures. So let's look and see how these measures fared and which ones came out on top. And before we do that, I'd like to take you through just a little bit of a tour of the EDGE form, which I see is not coming out so clearly, at least on my screen. I'm not sure how it's looking on everybody else's out there, but I will take you through this if it's tough for you to see. So what we have in front of you is an EDGE form, and these are accessible on the APTA website, and I will give you the information for that at the end of the presentation. But generally what you see here is the name of the measure, and this one is the Reintegration to Normal Living. And you'll see the title of the measure at the top, and I'm just going to go down and highlight some of the areas here. So what we see here is category 1, and this is acuity. And I talked about how a measure receives a rating, but each measure is going to receive more than one rating, because we know that there's a lot of variability in spinal cord injury, and what might be appropriate for one individual at one stage of their injury might not be appropriate for another. So the first category that a measure received was acuity. So acute, subacute, and chronic. Each measure received a different rating for each of these categories. Our next stop on the EDGE tour is complete or incomplete. So we also assigned a rating for each measure based on ASIA impairment scale, and we divided that into ASIA impairment scale A and B, motor complete, and ASIA impairment scale C and D, motor incomplete. So we can see that a numerical rating was applied for 5 different categories. Again, acuity, 3, and complete versus incomplete, 2 different ratings. Next, we see entry-level education. So a yes-no rating was assigned whether a measure should be introduced into entry-level education. So students should learn to administer a tool, or students should be exposed to a tool. Finally, should this tool be used in research? Again, a yes-no. And the main difference here is we were less concerned about clinical utility. Researchers have the luxury of potentially having more time, so we were not as concerned about how long a measure took to use. They also may have more access to higher cost equipment, so these types of factors weighed into whether we recommended this measure. Our final stop on the tour of the EDGE form is this link here. This is a link back to the rehabilitation measures database. We assigned all these ratings, again, based on psychometric properties and clinical utility, but we need support for those ratings. Where is this support housed? This support is housed in the rehabilitation measures database. If you click on this link, you'll find a description of the measure, the equipment needed to administer the measure, and then all the psychometric properties that support these ratings. So here you see the example of the rehabilitation measures summary. And we see the chronic spinal cord injury validity data for the Reintegration to Normal Living Index. What we also see in the rehabilitation measures database is the spinal cord injury EDGE ratings. So you can see again the pairing of the EDGE work and the RMD working together to give the user the best information. So in summary, each measure, I just gave an example of the Reintegration to Normal Living, will receive 8 recommendations. Acute, subacute, chronic, a number for that, based on ASIA impairment scale, motor complete, motor incomplete, and then recommendations for education and research. I think we've heard enough about process. I we're ready to move on. I hope it will be helpful for you as you use these resources in the future, and I'll help you understand how to use the resources. We need to understand that before being able to select the measures. And let's move on to hear about actual measures and which were highly recommended and recommended. And we'll apply that as well. If you recall, we looked at 17 measures that captured impairments in body structure and function. These are the constructs that we looked at relative to body structure and function that you'll recognize as commonly measured in your patients with spinal cord injury. Only 3 measures received a highly recommended or recommended rating across all 5 categories. So just to review, the 5 categories being acute, subacute chronic spinal cord injury, and motor complete and incomplete. If we break this down in other ways, so if we start looking at only chronic spinal cord injury and which body structure function measures received ratings of 3 or 4, that list gets a little bit longer. And we see some additional measures that fit this category. What you may notice here, so what do we have represented? We have pain, we have motor function represented. What is missing here? We don't see any measures related to tone. We don't see any measures related to aerobic capacity. Those measures did not receive highly recommended or recommended ratings across multiple categories. So that's something to keep in mind, and we'll come back to in a bit. If we're moving on to the activity domain, these are the constructs that were covered in the activity domain. Again, very common things that we work on in our practice and important for rehabilitation and spinal cord injury. These were the bulk of our reviews, which I think if you look at these constructs makes sense when you think about spinal cord injury rehabilitation. And if we look at the measures that received highly recommended or recommended ratings in 4 out of 5 categories, this one you see started here, gait and balance measures primarily, and then the FIM and the SCIM, the spinal cord injury independence measures, those received a 3, a recommended across all 5 categories. So again, if you look at this list, I'll give you a minute to read down that list. What is missing from this list? So again, we see 10 meter, 6 minute, the walking index for spinal cord injury. We don't see upper extremity function. We don't see wheelchair mobility captured. Certainly the FIM and the SCIM have elements of those, but measures primarily looking at those constructs are missing from this list. They did not receive highly recommended or recommended across multiple categories. Moving on to participation, again, you may recall 17 measures were reviewed for this category of the ICF, capturing these constructs here, again, important for life roles. And I want you to think for a minute how often you measure participation in your patients. And now think about how often you ask about it. What are your hobbies? Did you go out this weekend? Did you have trouble when you went out to dinner, when you visited your favorite restaurant? Did you enjoy going to that restaurant that you haven't been to in a while? But do you actually administer a standardized assessment related to the participation domain? I think we ask about these things all the time with our patients, but I don't think we do as good of a job measuring these things in a standardized way. Let's see how these measures fared in the process of our EDGE process. Highly recommended or recommended in at least 4 categories. We see the needs assessment checklist and the sickness impact profile. If we open this up to highly recommended in 3 out of 5 categories or recommended, this list gets quite a bit longer. And the reason for that is what's happened here is in the acute and subacute categories, most of these measures got a 2, which would be, to recall, reasonable to use but limited data in the target population, meaning that these measures just have not been studied in acute and subacute spinal cord injury. Most of the data is in chronic spinal cord injury. And if we think about the reason for that, these measures mostly are related to things that are happening when individuals are out and living in the community. Most of it has been studied in chronic spinal cord injury. However, if we think about the fact that average length of stays are shorter, people are going home earlier, and I would argue that we have many patients with spinal cord injury that are back in the community within a few months, or at least at home. And so it would be very appropriate to be administering these measures in our patients with acute and subacute spinal cord injury as long as they're not in the hospital. So that's something to consider, and I would advocate that despite the fact that maybe these measures did not receive highly recommended or recommended, the clinical decision making and clinical reasoning that would go into this would still, again, reasonable to use. And you have good clinical reasoning to say that these measures would be appropriate. And as your patient progresses into that chronic phase, you would continue to use it. We have an idea of what measures are recommended or highly recommended and which constructs and acuity level that they apply to. And so let's take a simple case to try to apply this information, because there were still quite a few measures on some of those lists, and we still need to make some informed decisions about which measures to use. We have a 32-year-old patient who status post motor vehicle accident 13 weeks ago, C7 Asia Impairment Scale C, and he's being evaluated in an outpatient clinic. He lives with his wife in a 2-story home with 3 steps to enter. He has a 2-year-old child and works as an accountant. I've provided his lower extremity motor scores here as measured by the International Standards for the Neurological Classification of Spinal Cord Injury to give you an idea of his function. We can see here that he definitely has some impairments in his hand function. He's most likely doing some ambulation, addressing it in therapy, possibly ambulating already. So again, just to give you a quick snapshot of what this gentleman is doing. His goals are to get stronger, to decrease pain, to walk better, to care for himself and his child, and return to work. If we organize his goals based on the ICF, we have get stronger and decrease pain in the body structure function category, to walk, care for himself, hand function in the activity domain, participation, return to work, his role as a father, and self-care, which actually spans the activity and participation domains. And we can ask the question, which measures are highly recommended for someone with a subacute and or motor incomplete spinal cord injury that relates to this patient's goals. So he was 13 weeks post, which according to the definitions from our work was subacute. And what you would do at this point is there on the neuro website, which I will show you, you can access all the results of the Spinal Cord Injury EDGE Task Force, and they are organized by construct. And you could quickly go and get a one-page summary and look and see which measures are highly recommended for these categories. And we could get an organization like this. So we can see that the highly recommended measures for, again, the constructs of interest, get stronger, decrease pain. We have the INSCI exam, which I've showed you has already been used. But there are definitely some strength and motor function that is not captured by the INSCI. And we also have other ways of capturing strength that is highly recommended. We have the handheld myometry. We also have some recommended measures, the numeric pain rating scale, and manual muscle test. In the activity domain, we have quite a few measures to choose from here. So we had, if you recall, I'll go back one slide here, we had walking, self-care, and hand function to be looking at. So we have the 10-meter walk test, the 6-minute walk test, the timed up and go, and the walking index for spinal cord injury. So we have a good group of highly recommended measures here that we can choose from. So if we go down to the recommended categories, we can eliminate the FIM. We're not in inpatient rehab, so we most likely would not be using the FIM in outpatient. The Berg may be a good option, as we might want to capture some additional balance. However, there is some data to show that there may be some ceiling effects in individuals with Asia Impairment Scale D, so that's something to consider. And we would know that based on further review of looking at the EDGE form as well as the Rehab Measures database. The spinal cord injury functional ambulation inventory, I don't think would give us much more than what we already have in our highly recommended measures. So again, you can see how we can go through the process and start eliminating based on this list. If we go down to the upper extremity function, I talked earlier about how this was a missing from our highly recommended and recommended list in multiple categories. These measures here, the capabilities of upper extremity functioning and the graded and redefined assessment of strength, sensibility, and prehension, are two upper extremity function measures that did receive a rating of recommended in individuals with motor incomplete spinal cord injury. They did not receive it in the subacute group. However, we have this information to help us make the decision for motor incomplete spinal cord injury. These two measures really came out on top for upper extremity function and spinal cord injury. And this is really worth mentioning because there are a lot of commonly used upper extremity measures in other neurologic populations that are used commonly where the data is lacking in spinal cord injury. And these two have data in spinal cord injury, and it's really worth taking a look at these two measures. Okay, so moving on to the participation domain. Again, here we have this long list that I showed on the previous slide. We have the recommended measures, the needs assessment checklist, the sickness impact profile, and then we have this list of recommended measures in Asia Impairment Scale CD, and then recommended in chronic. And I talked about previously how they are not recommended in subacute as far as receiving a 3. However, it's that category of reasonable to use but lacking data in the target population for subacute. I think I provided a good rationale why it would still be appropriate to use in this subacute population. So now we're faced with the challenge of how do you decide which measure to use from this long list? You're certainly not going to use all of these. And how do you go, where do you go from here? You might chat with your colleagues in your clinic to decide what measure you're going to adapt within your clinic and administer that to every patient. You might need to decide what's right for this patient based on this patient's goals. And how can you make that decision? And we talked about that being a barrier before. And this EDGE resources and the RMD is going to help make that decision. So let's take a look at a few measures and show how you can make an informed decision for this patient. And I'm going to pull out the satisfaction with life scale, the reintegration to normal living, and the chart as an example. So the satisfaction with life scale, this is a snapshot of that, and we can see, I'll blow it up a little bit bigger, we can get a little snapshot on the EDGE form. It doesn't tell us much more than we know from the title of the tool, but we know that it's a quick tool to measure satisfaction with life, but it helps us know that it's going to be a fast tool. And when we click on the link to the Rehabilitation Measures database, we can actually get to the tool itself. We see that it's a few statements. The patient rates whether they agree or disagree about life satisfaction. I've gotten the important things I want in life. The conditions of my life are excellent. Those are a couple examples. And I want you to be thinking about this particular case. Does this relate to this patient's goals? So here's that reintegration to normal living. So most of the research that has been done on the reintegration to normal living index has been in subjects with chronic stroke. The spinal cord injury literature has been focused on the chronic population. No information is available regarding how to interpret the results or meaningful change in score. And I'll pause here because that is very common with these participation measures and is often why these measures have not received greater than a 3 rating during the EDGE process. Many of them may have received good reliability and potentially validity, but lacking information on interpretation of results. And that's not to say we shouldn't use those measures. It's just to say proceed with caution as you get the results, or look at your patient individually and what does the change in your patient's score, how are they doing as an individual. But it's also telling us that we need more research in the area of interpretation of change and what do the results of these participation measures mean and how do we interpret that score. And that's just an area across the board in these measures that's lacking. Okay, back to the reintegration to normal living. So let's take a couple examples here. I'm comfortable with how my self-care needs are met. I spend most of my days occupied in a work activity that is necessary or important to me. I assume a role in my family which meets my needs and those of other family members. Does this sound familiar to the goals of the patient that we met earlier? Yes. So this should be kind of holding true with our patient here and very relevant. The chart. So the chart, again, we could read through this EDGE form, get some information on the chart. We would see that it's a spinal cord injury specific measure. Again, I know this is tough to read. I don't expect you to read it, but we would see all the different constructs that the chart fulfills and information about the chart. And then here are some sample questions. So the chart is lengthy, it's very specific. Transportation, can you use your transportation independently? Does it allow you to get all the places you would like to go? There's some examples. There's some information on money management. How much of your money do you control? Then there's some, are you up and about regularly? There's a bunch of questions following that. So based on just a couple minutes there, I was able to gather some information on 3 participation measures. And 1 focused on life satisfaction. 2 looked at more of a variety of constructs. 1 was more lengthy. 1 was still fairly quick and easy. So I think the clear choice for our patient there was the reintegration to normal living. And hopefully I've showed you how the EDGE form paired with the RMD really helped in the clinical decision making to see which one we were able to best meet the needs of the patient and potentially your clinic. I'd like to turn your attention now on how to interpret the scores that we obtained. And knowing the information will help in goal setting, help you to determine if the patient has made important and real changes in the constructs of interest. And I alluded to this information earlier on. As a quick review, the standard error of measurement, so this is the amount of error you can attribute to measurement error. The minimal detectable change is basically the minimal amount of change outside of the measurement error. And the minimally clinically important difference, typically what we have the least of in the literature as far as psychometrics, but really the amount of change that's been shown to be clinically important. So I've chosen the numeric pain rating scale, the 10-meter walk test, the Berg balance scale, and the reintegration to normal living as potentially a group of measures that we would use in this case. And you can see in green, these would be data that has been shown in spinal cord injury. Yellow would be data in related populations. And then the pinkish red would be obviously no data available. So for example, if our patient came in reporting 6 out of 10 pain, and by the end of our therapy sessions, he left with 4 out of 10 pain, we could really say that we made some important changes. And obviously that in combination with what we heard directly from the patient would complete that picture. And we could also use this, so example, the 10-meter walk test, we could use these values in writing our goals and knowing how much change to write the goal for to have it be a meaningful and important goal. The Berg becomes a little bit trickier, especially if we look at for people requiring assistance to ambulate. If you look at the literature, there is a large range of minimal detectable changes. And then again, the no data available. That's not to say we should not use this measure. Definitely better to obtain this data objectively. We talked before about how we're asking these questions of our patients all the time. It's much better to get that data in an objective way. But again, it's just a cautionary and interesting point to make that this data is not yet available. So I've also mentioned along the way that there's some areas of measurement and gaps in knowledge where future research is needed. And that's been a few themes throughout. So these are the ones that we need to mind the gap for. High level balance, tone, wheelchair skills, aerobic capacity, upper extremity function, and acute spinal cord injury. These are just areas where we really found through this process that we need more data on these measures. And these are areas that we work on and we need to measure in our patients all the time. And so the acute SCI, meaning that there's less data in those individuals with acute spinal cord injury. So the same measures that might have fared really well from a psychometric standpoint, there's less data collected in individuals in the acute spinal cord population. And if you take high level balance, for example, I talked earlier about how individuals with Asia Impairment Scale D, for example, have a ceiling effect on the Berg. We all know clinically that those individuals still have balance goals to work on. So what measure do we use to continue to capture their balance impairments and show change in their balance? So finally, thinking about stepping beyond the edge, and I've mentioned that there are multiple groups that have gone through this same process. And many of you out there might actually work with people with spinal cord injury and stroke and MS and Parkinson's disease. And looking at all of these different EDGE recommendations could potentially be overwhelming. And so I want to mention that there is actually in the works clinical practice guidelines for a core set of outcome measures. And this is being done through the neurology section of the APTA. And again, looking at combining the work of the EDGE groups and utilizing a more formal systematic review of the literature to do this. And so this will be available for public comment in 2016 and hopefully ready by early 2017. So be looking for that. It's really exciting work. So here's where maybe we started today when we thought about the EDGE and looking over the EDGE. And I'm hoping that now many of you will be thinking more about these tools when you think about EDGE and being able to utilize this resource to improve your use of outcome measures and ability to overcome some of those barriers that we spoke about today. I would like to acknowledge that this webinar was supported by Grant 739 from the PVA Education Foundation and improving psychosocial outcomes following spinal cord injury or disease with measurement resources. I would also like to acknowledge the neurology section of the APTA and the Spinal Cord Injury EDGE Task Force and all the people that I worked with in and throughout this process, and also the Rehabilitation Measures Database team. It's a wonderful group of people that we worked with. And finally, this is where all this information can be found. So if you go to the neurology section website at neuropt.org to the professional resources tab, you can find, this is free to anyone to access. You don't have to be an APTA member to access this information. And also the Rehabilitation Measures database at rehabmeasures.org.
If you have any questions, please feel free to email us at rehabmeasures@ric.org. Thank you for attending.